Yeah. Okay. So when we were deciding about the topic, then Manpreet ma'am was like, we'll go with endometrial hyperplasia, since many general practitioners, since it's a mixed audience, and general practitioners would be like helpful if at all, because many of them will be having a dilemma like how to go about with endometrial hyperplasia. So we thought we will, and since endometrial hyperplasia is a, so I'll be discussing these topic under these headings. So first of all, what is endometrial hyperplasia? What are the risk factors involved with hyperplastic endometrium? How do we classify that? How do we diagnose? What are the treatment modalities, and how do we follow up such a case? And some special scenarios involved with that, and some recent advances involved, which includes the biomarkers as well. So to begin, endometrial hyperplasia, it's a precancerous lesion. It's a non-physiological, non-invasive disordered proliferation of endometrium, which results in an increased volume of endometrial tissue with alterations of the glandular architecture of the endometrium. And the gland to stroma ratio will be always high. So since it is a precancerous lesion to endometrial carcinoma, and endometrial carcinoma is one of the most common genital malignancy, female genital malignancy in worldwide. So we need to diagnose endometrial hyperplasia and treat it. It is reported around 2 lakh new cases of endometrial hyperplasia every year in Western countries, and it accounts for 10% of the premenopausal women coming with abnormal uterine bleeding, and 15% in the postmenopausal women. So now, what are the risk factors or the causative factors with endometrial hyperplasia? There are non-modifiable risk factors and also modifiable risk factors. There are endogenous causes and exogenous causes. Basically, endometrium is a tissue which will grow with the effect of estrogen. So the age factor is involved in that, nulliparity is involved in that, some ethnic factors are there, and of course family history is also important. Coming to the menstrual, like I told you, it is under the effect of estrogen. So early menarche, late menopause, the number of years in the postmenopause, prolonged perimenopause, all, and the comorbid conditions, that is which is associated with the endogenous factors like obesity, diabetes, polycystic ovarian syndrome, and some functional ovarian tumors, and the genetic syndromes. And coming to the iatrogenic or the exogenous factors, the hormonal therapy, hormone replacement therapy, which we give during the menopausal years, the tamoxifen therapy, which if at all it is going on for a long term for the breast cancer. So all these exogenous factors also will be playing a role in endometrial hyperplasia. So similarly, like I told you, the endogenous factor, most commonly obesity, because of the high insulin levels. Similar condition is there in PCOS, and that is why there is the excess androgenic environment will lead to conversion to estrogen, and then there is an hyperestrogenic state. Then the unopposed estrogen from any of these factors can cause a hyperplastic endometrium. Now, the classification has evolved since 1994. Way back then, we used to call that, like when we were doing a post-graduation also, like we used to call simple hyperplasia, complex hyperplasia without atypia, and simple and complex atypical hyperplasia. So that was in the classification was, but as the years passed on, the classification got changed, and then it was called endometrial hyperplasia and endometrial neoplasia. Then to avoid confusion, there was an EIN classification, that is endometrial intraepithelial neoplasia, benign, and EIN. But to simplify everything, the WHO has told a new classification which is currently followed, that includes only 2 types of endometrial hyperplasia. One is without atypia and another is atypical endometrial hyperplasia. So in endometrial hyperplasia without atypia, it includes everything, simple and complex without atypia, and atypical endometrial hyperplasia includes endometrial intraepithelial neoplasia as well as simple and complex atypical hyperplasia. So to avoid the confusion in the histopathology, this classification is the working classification right now followed. Coming to the histopathologic pictures, I would like to mention here, this is a normal proliferative endometrium. We all know during the proliferative phase, under the effect of estrogen, there is the gland cells are looking like this. So we can see there is the gland and the stromal ratio is quite nice, and there is no increase in the ratio. The glands are all normally organized. But whereas in hyperplastic endometria, this is the without atypia. So here the glands are already dilated. The gland to stromal ratio is increased, that is more than 50%. The glands have come up, the stroma is decreased. However, here the regularity of the glands is maintained. So there is no irregular pattern or no convolutions or no complexity involved here. So this is a simple dilated glandular pattern. So that is without atypia. When we see this endometrial intraepithelial neoplasia or atypical hyperplasia, you can see again there is increased glandular stromal ratio. There are complex glands, the glandular convolutions are here, and also the mitotic features are also seen in these cells. So this is the same picture in the high power. So this is how the pathology picture looks. So in atypical hyperplasia without atypia, so we have the low level of somatic mutations. We have a genetic factor involved, like I told you. So the mutation level is low here, whereas in atypical hyperplasia, the genetic changes are more, and the factors involved are mutations of the PTE and KRAS genes. And here the risk of coexisting invasive endometrial carcinoma is less than 1%, whereas here it is more. The coexisting endometrial, it is around 10%, but the disease progression is around 25 to 30% in atypical endometrial hyperplasia. So how do we diagnose now? So diagnosis, like I told, a thorough history and examination to rule out the causes involved in the estrogen excess, the hormonal milieu. So we need to take a complete history and examine and rule out any ovarian cancers or any other factors which are responsible for hyperestrogenic states. Then we have to do a pap smear according to ACOG. A pap smear also, we can also find some atypical gland cells or endometrial glands when we take a smear. So we need to do that also. And transvaginal ultrasound is a gold standard. So always we need to do a transvaginal ultrasound to look for the thickness of the endometrium, any irregular endometrial pattern. Then once we find there is any abnormal endometrium in the sonography, we need to sample the endometrium. So there are different sampling techniques. We have outpatient or office endometrial sampling and inpatient sampling. Then of course there is the hysteroscopy guided endometrial biopsy. Then once we sample the endometrium, we are going to examine it histologically. However, there is insufficient evidence as the CT with CT MRI as a diagnostic modality. What is the role of transvaginal ultrasound? So in premenopausal women, we have to do a transvaginal sonography. The RCOG says any women with abnormal uterine bleeding, any women with PCO, any women coming with absent withdrawal bleeding, we have to perform a TVS. And when the endometrial thickness is less than 7 mm, the hyperplasia is very unlikely. So above 7 mm, we have to think of endometrial hyperplasia. Whereas in postmenopausal women, all the women coming with bleeding complaints have to be undergone done with a TVS. And any irregularity in the endometrium, any increase in thickness have to be biopsied. The cutoff here is 3 to 4 mm. if it is under 3 to 4 mm endometrial thickness, the risk of endometrial cancer will be less than 1% according to the studies. But any endometrium more than 3 to 4 mm has to be biopsied. Coming to the sampling techniques, like I told you, because of the complex pattern in the histopathology, it is quite challenging for the pathologist to rule out completely invasive cancer on a office biopsy samples, because like the studies have told, in a non-hysterectomy samples, it's quite challenging to rule out completely invasive. They will give a hyperplastic endometrium with a TPA but invasive cancer, unless there are markers like cribriform pattern or maze-like pattern. So these are the distinct marker to call them as invasive cancer. So it's quite challenging. That is why we need to give a thorough history along with the whenever we are giving. So this is whenever we are giving a requisition to the pathologist, the history pattern has to be documented properly, and also the examination findings, preferably the scan findings, also have to be documented. So there are two types, like I told you, the biopsy techniques, office biopsy and inpatient biopsy. And it is noted that the studies have shown that office biopsies has also equally high diagnostic accuracy rate in detecting hyperplastic endometrium. But the ACOG says, that is the American College of Obstetricians and Gynecology, they say hysteroscopy guided biopsy can sample both focal pathology and the background endometrium, and it can yield a higher detection rate, because we are visualizing the endometrium and we are seeing where exactly there is a pathology, and also that lesion as well as the background endometrium thing can be sampled. Whereas in the office and office biopsy or inpatient biopsy, that is dilatation and curettage, we may be missing only about 50% of the cavity can be included, but the rest of the 50% may not be biopsied. So it is always a high detection rate is there with a hysteroscopy guided biopsy. The treatment guidelines, what are we actually heading with the treatment? So the main principles involved here will be, one is, since it is a precursor of endometrial malignancy, we need to prevent the progression of endometrial malignancy from a hyperplastic endometrium. So that is first thing. Then we need to rule out whether there is any coexisting malignancy already. And also we need to treat which is best suited for that particular patient. Now, when we get a biopsy pathology HPR report as without a TPA, so we have to keep in mind that in endometrium without a TPA, the risk of progression to invasive malignancy is less than 5% over 20 years. So, but still there is a risk of progression. But there are two methods here. So conservative, like Kasturi madam was initially telling, conservative method is always there, and conservative method, there is high chances of spontaneous resolution is there if at all the hormonal milieu is corrected. Supposing there are reversible causes like obesity, or if at all the woman is using hormone replacement therapy or any high dose estrogen preparations, if she is taking, those things can be stopped, and once the hormonal milieu is corrected, there is chance of spontaneous regression. And one more is progesterone treatment. But according to RCOG, progesterone therapy has a higher disease resolution rate. So with this only observation or this thing, it is just 70 to 80%, whereas with progesterone therapy, it is 89 to 96% disease resolution rate. So that is why it is better. We need to put on hormones. Progesterone treatment, like if at all it is indicated, like I told you, it has a better disease regression rate, and if at all initially we thought it would spontaneously regress, and if it fails to regress, then we have to start the progesterone immediately. Then any symptomatic woman with abnormal uterine bleeding needs to be treated with progesterone. So there are oral progesterones and also a locally device is there, that is LNG IUS we call, that is levonorgestrel intrauterine system. So this is a intrauterine device, just like copper teat will be, but it is a hormone containing device. That is, the progesterone here is levonorgestrel, which will be inserted in the uterus. The preferred method is always, first line method is levonorgestrel, that is LNG IUS, since it has low side effects and also got a higher rate of disease resolution, and the chances of bleeding will be less. The efficacy is more because obviously there is a high local concentration of levonorgestrel at the endometrium. So that is why always in endometrial hyperplasia without atypia, the first line treatment will be medical management with progesterones. So preferably in that, LNG IUS will be the first line. And with the oral progesterone, always we need to put on continuous progesterones in case if the woman declines or does not want LNG IUS. So continuous progesterones will be always better than cyclical progesterones, because cyclical progesterones are known to be very less effective in the disease regression. So continuous progesterones will be medroxyprogesterone acetate 10 to 20 mg per day, or norethistron 10 to 15 mg per day. So now how long we need to add these progesterones continuously? So the duration of treatment, the minimum duration of treatment is for at least 6 months. So whereas if we are putting a LNG IUS, it covers for 5 years and the symptoms would be completely reduced. But on oral progesterones, it will be at least for 6 months. And how do we have to surveillance now, or the follow-up of the patient? Every 6 months, we have to do a outpatient endometrial biopsy. That is, we have to take a endometrial biopsy every 6 monthly interval. And until we get 2 consecutive negative biopsies, we need to continue the treatment. So that is the follow-up of the endometrial hyperplasia without atypia. Supposing if there is any abnormal vaginal bleeding after completion of the treatment, that is, we call, now it is a relapse. So again, the patient has to be further viewed. And supposing if there is a woman with high BMI, or if she is treated with oral progesterones, these are the patients which have high rates of relapse. So the obese patients and those treated with oral progesterones, when compared to LNG IUS, have high relapse rates. So even in these patients, we have to do a 6 monthly endometrial biopsy for at least 2 years. But once there is a negative endometrial biopsy, still we need to follow these patients with annual endometrial biopsy, unlike the other patients. So every yearly, we have to still do the biopsy in obese patients. Now, this was about the conservative management. If at all there is a surgical option, what is the surgical options? When we have to take up surgery as the treatment modalities in endometrial hyperplasia without atypia. So if at all there is a progression to atypical hyperplasia during the follow-up, when we are doing the surveillance, if we find there is progression to endometrial hyperplasia when we are doing 6 monthly biopsies, then those are the patients who have to be given the surgical options. If there is no histological regression even after 12 months of treatment, so we are doing the follow-up, and if there is no histological, this histopathology picture is the same, so then also these are the patients who will need surgery. Like I told you before, relapse even after completing oral progesterones are the patients who will need hysterectomy. Or the persistence of bleeding symptoms even on hormonal treatment, these are again the patients who need hysterectomy. And of course, if the woman declines endometrial surveillance or she is not compliant with our medical treatment, so these patients we need to again give the option of surgery. So postmenopausal women requiring surgical management. So whenever we are doing hysterectomy for a postmenopausal, it is always bilateral salpingo-oophorectomy or the total hysterectomy with total hysterectomy. So for premenopausal women, the decision of ovaries, again, it has to be individualized. It is depending on the consultant, but it is always preferable to do a bilateral salpingectomy to reduce the risk of future ovarian malignancy in a premenopausal woman. Of course, the mode of hysterectomy, the laparoscopic approach is preferable because it has a short hospital stay, less post-operative pain and quick recovery. The options like endometrial ablation is not recommended in endometrial hyperplasia because the endometrium would be completely destroyed and there would be intrauterine adhesion formation, and in such conditions it is highly impossible to do the histological surveillance. So these ablation is not recommended. Now coming to atypical endometrial hyperplasia, when we get a atypical hyperplastic endometrium, so because it has a 29% risk of progression to CM endometrium within a short span of 5 years. So that is why we need to treat this on priority basis, and we have to treat it completely. So the option here is always a total hysterectomy because of the risk of underlying malignancy or progression. Even the coexisting underlying malignancies as high as 10%. That is why always complete cure with total hysterectomy is preferable approach, and again laparoscopic approach is preferable, and it is seen that there would be no benefit from the intraoperative frozen analysis or surgical staging or a routine lymphadenectomy. In postmenopausal women, again we have to do a bilateral salpingo-oophorectomy with hysterectomy, and premenopausal, again the ovaries need to be individualized. Again bilateral salpingectomy is to be considered, and to reduce the risk of future ovarian malignancy. Again, ablation is not recommended. Now coming to those patients who wish to retain their fertility or who are not the patients who are suited for surgery. So here the counseling plays a major role because we need to carefully counsel them, because there is a coexistent risk of endometrial malignancy in these patients. There is a risk of progression to endometrial malignancy. There is a risk of coexisting ovarian cancer. There is a risk of metastasis and of course death. So these things have to be counseled to these patients. And our goals are to stabilize the disease, to reduce the risk of progression, and also to medical management of these patients. Thus, the investigations include the tumor markers, the radiological findings, the histopathological findings. So all this, these treatments, these patients will need a multidisciplinary approach in considering the opinion of the gynae-oncologist. So it has to be based on an individual approach treatment. It is possible to provide fertility sparing treatment to these women if indicated, but the very small number of studies are there to support these. In these patients, we have to aim to rule out invasive endometrial carcinoma and coexisting ovarian carcinoma. That is why, like I told you, histopathology, histology, imaging, tumor markers have to be considered. And in these patients, LNG IUI would be the first line treatment, and oral progesterones are the second line. Once fertility is no longer required, we have to immediately offer her hysterectomy. Well, how do we follow up these patients? Endometrials in these patients, the biopsy should be done every 3 months until 2 consecutive negative biopsies are obtained. And here, in asymptomatic women or those patients with histological disease regression, we can go with the long-term follow-up with endometrial every 6 months until a hysterectomy is performed. And if there is a failure to regress by 12 months or evidence of progression to cancer in such patients, we should strongly recommend hysterectomy in these patients. And also there is a risk of relapse is very high in the first 2 years from diagnosis. And again, if there is a relapse, hysterectomy has to be recommended. So this is again the same thing, flow chart showing what we have to do with the endometrial hyperplasia with ertipia and without ertipia. So the differential diagnosis in cases of endometrial carcinoma are obviously endometrial hyperplasia or endometrial cancer, endometrial polyp, wherein to rule out polyp we need to do a sonosalpingography or hydrosonography. And of course, a diagnostic hysteroscopy can confirm the presence of polyp, and endometritis is also one of the differential diagnosis with the irregular endometrium or focal thickened endometrium. Now, some special scenarios where we need to consider for those patients who want to conceive, or those patients who want to, in cases of endometrial hyperplasia, we have to achieve a disease regression as early as possible. Like we have already seen, we have to put on LNG, we have to do a follow-up every 3 monthly, and once there is a single endometrial sample, we have to there has to be at least one sample showing a disease regression before we attempt a pregnancy, because that is known to increase the implantation and clinical pregnancy rates. And in LNG IUS, it is seen that the regression of the disease is very high, and implantation rates are also high when the woman is put with LNG IUS. And of course, the fertility specialist opinion has to be considered when we are treating these patients. And it is seen that assisted reproductive methods have to be given, options have to be given, because they have known to cause high birth rates and may prevent the relapses. Another scenario is endometrial hyperplasia, and if the woman is on hormone replacement therapy. We all know if a woman is with an intact uterus, we should not give systemic estrogen only hormone replacement therapy, and always it has to be a combined HRT. So we have to warn the woman on HRT to prompt and report any unscheduled vaginal bleeding. So if the woman is on sequential HRT and wishes to continue hormone replacement therapy, we have to ask her to change to continuous progesterone intake. It could be LNG-IUS or combined hormone therapy. If she's already on combined hormonal therapy, and if she still wishes to continue hormone replacement therapy, then we have to seriously review the need of her to continue the need of HRT, and discuss the limitations with the continuing HRT, and thus you have to give her the options of LNG. Another scenario is if the woman is on adjuvant treatment for breast cancer. So, of course, here the oncologist's opinion again has to be taken. If the woman is on tamoxifen for breast cancer, we have to counsel her the risks of increased risk of endometrial hyperplasia with tamoxifen, and you have to encourage, again, if there is abnormal uterine vaginal bleeding, she has to report it immediately. It is seen that if the woman is on aromatase inhibitors like anastrol and all, then they are not known to increase the risk as much like tamoxifen. And what is the role of progesterone therapy in women on tamoxifen? Though we know that LNG-IUS definitely prevents polyp formation, reduces the incidence of endometrial hyperplasia, but in patients with breast cancer, it is uncertain what is the effect of LNG-IUS on breast cancer. That is why the use of LNG-IUS in breast cancer patients cannot be recommended. So we have to, if at all we are managing such a case who will develop endometrial hyperplasia on tamoxifen, we have to seriously again reassess the need for tamoxifen in her, and then again we have to manage the endometrial hyperplasia in conjunction with the oncologist. Now, if at all endometrial hyperplasia is confined to a polyp, then the best treatment would be removal of the polyps, and again the rest of the endometrium also has to be biopsied, and then the management would be according to the histopathological diagnosis or classification of endometrial hyperplasia. So now coming to some immunohistochemical biomarkers, like we have seen along with the histopathological pictures, we can have some biomarkers which can predict the likelihood of transition from endometrial hyperplasia to endometrial cancer. The biomarkers are nothing but the characteristics that can be objectively measured and evaluated as indicators of normal biological process or pathogenic process or pharmacological response to a therapeutic intervention. So what is an optimal biomarker? It must be reliable, it has to reproduce and distinguish between normal, benign or pre-malignant, malignant, and so, but here there is no single candidate which will fulfill all these criteria, and that is why the search for an optimal biomarker is always on. So this is a picture showing how the genes or the mutation progression takes place. So these are the glands, the endometrial glands, normal looking glands. Once there is a mutant, there is the pre-malignant cells look like this, and then there is a cancer cells look like this. So always there is a tussle between the promoter versus suppressor genes, then there is mutation, and then because of the accumulation of multiple genetic events, there is a hyperplastic or abnormal endometrium. So the genetic mutations can be on the PTEN, PAX or HAN2. So these are the, we said, the regulators of steroid action or inflammation. There are estrogen receptors, which are alpha and beta receptors, progesterone receptors, cyclooxygenase 2, and tumor suppressors are PTE and P53. So any mutation in any kind of mutation in these genes can be the cause for endometrial hyperplasia. So transcription factors are there, PAX2, HAN2, so mismatch repair, and so on. So to conclude, endometrial hyperplasia without atypia and atypical hyperplasia, these are the only two classifications which is followed now. And in case of hyperplasia without atypia, there has to be a minimum of 6 months treatment duration, and follow-up has to be every 6 months until 2 negative biopsies are obtained. And LNG-IUS is always the first line medical treatment. Then continuous progesterones and for patients without atypia. In patients with atypical endometrial hyperplasia, the follow-up has to be every 3 monthly. If at all, we have to retain her fertility. Otherwise, the treatment for atypical endometrial hyperplasia is total hysterectomy with bilateral salpingo-oophorectomy in postmenopausal women. The role of qualitative or genetic biomarkers is yet to be determined. So, to conclude, thank you so much for the patient listening.
Kasturi ma'am, you can answer.
Yeah. Unmute ಆಗ್ತಾ ಇರಲಿಲ್ಲ ಅದು. Now I am audible?
Yes, audible, ma'am.
Yeah. Thank you, Shruti. It was a very excellent talk on endometrial hyperplasia. Every details we have dealt with, every minute details, and very practical talk. And especially the special scenarios was too good. And it needs, emphasis on special scenarios, because those are not the routine ones where we get, and when we get, like, everybody is in dilemma, what next? So you have really dealt in detail what next to be done, and you have told all the delegates, like, they did not fear if it comes suddenly endometrial. There are so many hormonal, both conservative line of treatment, whether it may be oral or injectable or LNG-IUS. And LNG, I'll tell you, LNG, our practical experience, LNG-IUS is excellent. Whatever, even with 17, 18 mm endometrium, we have seen that with LNG-IUS, it just comes to 4 and 5 after a few months. And
Yes, ma'am.
The people who are having heavy bleeding, just they have amenorrhea. So the younger group, I think we should promote more and more of LNGIUS and save their uterus. Our goal should be save uterus.
And patient satisfaction is really good, ma'am, with LNGIUS.
We have to just counsel them, you know.
Yes.
We have to just tell them that they will have irregular cycles and they will have amenorrhea. So if they accept that, and if we have told prior, then they will be. Otherwise, some people like they'll be coming and telling, you know, after putting that we didn't have menses, and they'll attribute everything for not having menses. If they become a little fat also, they'll tell periods are, we are not having periods, so all the dirt is not going out. So we are becoming obese, we are becoming fat. That's what they tell. They think that with the menstruation, all the dirt from the body, all the fat from the body is going out every month. So if we spend little more time and if we tell them properly, tell them and counsel them that this is excellent for their health, and early hysterectomy is going to definitely damage the blood supply to the ovaries, and it can have long-term effects. So if we counsel them and tell them on this, I think there will be good acceptance and we can treat more and more patients conservatively. And yes, atypical, I agree, because you never know when it turns oral invasive malignancy. But whenever it is non-atypical, we should give more emphasis on conservative line of treatment and remove all the superstitions, all the myths, all the wrong understanding from the patient's side. You know, really so many myths in and around the menstrual cycle, unimaginable. They come with so many things. I think if we can spare some more time, 5 to 10 minutes, and remove. And once we tell, they get convinced. So that is with this. If there are any questions, we'll take up. If there are any questions in the chat box.
There is a question in the chat box, ma'am.
Yeah.
How to take a biopsy for follow-up when we already have inserted an LNG-IUS? When it's in situ, then how to take a biopsy?
Actually, when it is in situ, most of the time we monitor them with ultrasound, see the endometrial thickness most of the time. And only very rarely necessary, it is still very thick, we can always take a pupil biopsy. And if we can put a probe, keep a probe on the abdomen, and under the ultrasound guidance, we can take pupil biopsy, that will not dislodge the LNGIUS. I think ultrasound guided would be much better. OPD only can do it.
The next question by Dr. Deepashri, I think Shruti ma'am has already answered this. After putting the LNG-IUS, how often to do endometrial biopsy? I think you already said 6 months.
Ma'am. Pupil biopsy with ultrasound guidance, madam said.
No, how often?
Yeah, how often is that's what, without atypia, if it is, then every 6 monthly we need to do a biopsy. And until we get at least 2 consecutive negative reports, we have to get.
And with atypia?
With atypia, every 3 monthly, ma'am.
Okay. Okay. Ma'am, I have some few questions of, okay, now one more question is endometrial thickness, how to measure when the IUS is in situ? Same method.
Same method, we told ultrasound guided pupil.
No, how to measure the endometrial?
How to measure? Okay.
How to measure?
Yeah, with transvaginal ultrasound, the acutensity is different between the when we see that this thing and the endometrium. So we can, with after doing TVS, you get a clear outline. You can measure.
Okay. So same with TVS as we are doing with without an IUS in situ.
Yes.
We don't have to do any calculations because of the IUS. Okay. Ma'am, I have. Okay. Now, next question is, if endometrial biopsy is not possible practically due to cervix, which is not negotiable, what's the alternative to do endometrial biopsy?
If cervix is not negotiable.
Because of the IUS.
No, it is because in the cervix it's only the thread. It is always negotiable.
No, ma'am. I think it is mostly in the postmenopausal woman she is asking, because many times in postmenopausal women, cervix is atrophic and it is not able to pass the pupil inside. But
okay, that time we have to dilate
yes.
and put it. Then it cannot be a OPD procedure. If it is totally stenosed, If it is totally contracted, then it is not a OPD procedure. Then it has to be done under anesthesia. We have to dilate the cervix, then only take the biopsy. Otherwise, you will not get the tissue. Just don't get it.
And I think, ma'am, with the postmenopausal women, we are not that desperate to give a conservative treatment and
Yes,
following her up 3 months, 6 months. It's better
No,
to
no, yeah.
move the uterus. And,
Yeah,
yes.
postmenopausal with TPR, definitely it's an indication for hysterectomy.
Yes. Ma'am, I have a question now because I don't see any other question here. I have a question now. So the second line of treatment, Dr. Shruti, as you said, that either MPA or norethistron, which
yes,
would,
ma'am.
we have both available, which is better.
Ma'am, I prefer norethistron because I feel with that the results will be good. Yes, ma'am.
Ma'am, Kasturi, ma'am, you have anything to say to that?
We usually should turn to Depo-Provera injections, injectables, because our patients are not very compliant. No, so we should, if they are not if they don't want LNG-IUS, then we should turn to this
Ma'am,
Depo-Provera.
Depo-Provera, how often 2 shots you give? Like every 3 months?
Every 3 months.
Yeah, for 6 months.
And common also available Antara injection is there. We do that.
Yes.
Because what happens, so when we give orally, means what I'm talking about the scenario, what they're not taking it completely.
Yes.
They take for 20 days, 25 days, they just leave it.
Yes.
At the most, means once this thing they have bought and gone, they'll take only that and they'll leave. And they end up in more problems of bleeding, which cannot be controlled even with hormones. They end up in a more bad scenario than they were what they were with the irregular hormonal treatment. It's extremely difficult to treat a patient who is on irregular hormonal treatment and having bleeding due to that. It doesn't respond to anything.
Right.
So, yeah, so many times it has so happened that those who could have managed conservatively, because they have taken so much irregular this thing, we'll have to do curate and remove that. Sometimes we have ended up in that, even though we don't want, because of the irregular treatment and they're on and off everyday bleeding. To stop that, we have to just scrape that. I mean, such scenarios we end up only because of that. So our patients are very less compliant with oral progesterones, so most of the time. But if they are compliant, as norethistron would be good. When both are equally, but they are more comfortable with norethistron patients taking this. The complaints which nausea, they don't have much with.
Yes.
Okay. Even I have that experience with norethistron. Response to norethistron is faster and better. MPA. Okay. And ma'am, one more question that I have is, now, supposing after, as you said, in ATPia, patient is wanting fertility sparing this thing, and she wants to conserve the uterus, and we have put the LNG. And after minimum one negative biopsy, we have removed the LNG, and we want her to conceive now. And of course, supposing artificial ART and all is good, patient is not affordable for ART, and we want her to conceive in her normal cycle. Now, how soon after this removal of the LNG will she be, really getting an endometrium, which is good enough for her to conceive, or should we add on estrogens? But estrogens again
again they are the precursors for
yes. So that is not an alternative. Yeah. So how soon? Sorry, ma'am.
As early as possible.
As early as possible.
Because again, if she lands up in endometrial hyperplasia, again it's not good postpone. So now the effect of suppression is there. Better take that advantage and then ask her to go ahead with the.
But as early as possible means her endometrium will not be responsive to the embryo at all.
I mean, it doesn't suppress so much in 2 months. Means it will not become atrophic.
3 months. No, 3 months and then a biopsy. Supposing it's still positive, then we continue and take another biopsy after 3 months. But we cannot give, because as you said, we cannot give any add-ons like estrogen. So we have to wait for spontaneous.
Spontaneously she has to. Otherwise, assisted is always better, ma'am. But if the patient is not affordable, then we don't have any option.
Because again, because it's atypical, no, we cannot, again it will become hyperplastic. So whatever, if she conceives early, then she'll have progesterone environment. So we are not worried about it. The in vitro environment is a progesterogenic. And also we can add progesterones during pregnancy. So that will also protect her. So better she conceives early in those scenarios.
Okay. Okay. Ma'am, one last question, I think then we will wind up. Dr. Veena N is asking when to start progesterone, from the second day itself?
For this hyperplasia.
Yes.
Yes, we can start from second day.
Immediately, no, madam?
Immediately
Anyway,
we'll start, madam.
yeah.
Immediately.
Yeah, okay.
15 mg.
I don't think there are any other questions. So, is there any other question from the audience?
But only thing, we have to be careful in a patient with history of any deep vein thrombosis or thrombogenic events in the past, or she is prone, like because of the family history or some aplasia, everything. We should be careful, because I have seen a case who was on progesterone who came with deep vein thrombosis of her limb. So we should be careful. At least 2 or 3 cases I have seen, not because of estrogen, by progesterone only they had DVTs. So we should be very careful in selecting the cases also.
With which kind of progesterones, ma'am? Any like?
No, she had taken treatment in Hyderabad.
Okay.
Actually, she was on northeastern only.
Mhm.
She just came with pain in the limb to us. And when we saw she had DVT.
Okay. Okay. So that also has to be monitored along with anything.
Yeah. If they have any of this history, we should be careful. It's not like we just can prescribe it. Yeah, careful.
Okay. And ma'am, for a resource limited setting like ours, how important are the biomarkers, or is clinical monitoring and clinical treatment enough? Because I think biomarkers are more of a theoretical.
Yes, ma'am.
For us abroad, yes, they do everything and anything. They really work out.
Clinical this thing is, I think we are
enough for us for the time
close
being. Okay.
Ma'am, even if we diagnose, like we
see.
don't have the, I mean, exactly like what we have.
John, you are
we're
able to hear
supposed
me?
to treat that.
Okay. One last question. Progesterone for how long? I think Shruti ma'am has already answered that. And
6 months.
6 months continuously we have to give them. Yeah.
Yes. I think this was a really fruitful session. And yeah, as there are no more questions, any more comments from our stalwarts like Dr. Geeta ma'am was here. And I would like to propose the vote of thanks. At the outset, I thank Dr. Lakol sir, our Honorable President, for having presided over this function and for having given his expert comments and his lots of encouragement.
Thank you, madam. Thank you. Very well conducted. Nice.
Thank you, sir. Thank you.
Go ahead, madam.
I really thank.
More and more to come, madam. This year.
Yes, sir. Thank you so much, sir.
Okay.
Under your guidance, sir, we will do it, sir.
Yes.
Geeta ma'am is there.
So many seniors and starwards are there,
Yes,
madam.
sir.
You
Yes,
can
sir.
take it.
Yes, sir.
Nice. All the best.
Thank you, Manpreet ma'am, Kasturi ma'am, for believing in me. I hope I've done justice to the.
You have done wonderfully.
Good.
I'm coming to that. Please let me finish my vote of thanks.
Okay.
I thank Dr. Srinivas sir for having honored us with his presence. I also thank Dr. Karunakar sir, because I have in the past, I think 3 or 4 days, I've really bothered him a lot with the protocol, because this is one of my first webinars as WDW. So I didn't want to go wrong anywhere. So I have really bothered him, and he stopped taking my phone in between because it was probably irritating for him. Dr. Kasturi ma'am, it was really an honor and to have you with us. And I have always told everybody that even if Kasturi ma'am is the chairperson only, and she is not the speaker, and even if I or anyone else has prepared the best of the topic in entirety, there will always be 1 or 2 things that we might have missed out, with Kasturi ma'am will really bring out, and it's absolutely clinical importance. So thank you so much, ma'am, for having presided over the session in such a wonderful way. And we are going home with a very good, clear-cut message. Shruti, your talk was very informative. It was simple to follow, and you went even, and despite all those technical flaws, you maintained your calm and the
I'm
delivery
really
of your
sorry,
talk.
ma'am. I had really
No.
no idea what was happening actually.
No, that's okay. It's okay. It's happened to the best of us.
Yeah.
But you went around about it in a very calm manner and you relayed the message in your talk. Preparation was good, and the discussion, I think whoever was listening to the discussions, a lot of things we are going back home, a lot of clarity topic. And I also thank the technical team. Of course, there were glitches, but without their support, we will never be able to do such webinars with so much of, what to say, this thing that everything will be fine. We are assured that everything will be fine in the end, even if in the beginning we make some mistakes, because we do make some mistakes. We are not the technical people, they are the technical people, and they somehow sort it out. Shri Ashwath Narayan ji from the IMA office, very helpful person, and anytime, every time we ask any question to him, he'll just come back in 3 or 4 seconds with the response. And last but not the least, I thank the delegates who were patient with us and who went through the sitting and the glitches in the beginning in a very patient manner. And they also came out, listened to the talk so carefully and came out with lots of questions. I thank everybody for being with us for this webinar, and I hope that we will have you again as delegates later on. And
You mentioned John, madam.
Sorry,
John.
Technical sir, Mr. John and Mr. Anand. That's what the technical team has made it possible for us. Without them, we won't do it, sir. We cannot do it. And whatever the hassle, they will take it out within, I think, 4 minutes is the max they have taken ever to sort out a technical glitch. So thank you very much, John and Anand. And Shashikala ma'am, thank you for
yes,
your ceremonies for the webinar. I thank you all, and good night and have a safe.
Happy New Year.
Thank
Happy
you.
New Year.
Thank you, ma'am.
Happy New Year in
Happy New Year
advance.
to
Yes,
everyone.
we will be meeting now in the
Yes.
next year only. Thank you so
Yes,
much.
correct.
Thank you so
Happy
much.
New Year.
Thank you,
Thank
everyone.
you.
Thanks. Thank you so much.
Good night. Good night.
Good night, everyone.